Okay. Yeah. So we're still looking at most of the things we looked at yesterday, things to do with the nutrition assessment, things to do with the goals of the nutrition therapy, being able to enhance the quality of life of the individuals, the nutrient requirements. We saw things to do with the energy and etc. Clinical observations, and also we looked at other factors that are contributing to the wasting, the malabsorption of the nutrients. However much there is intake, but then there could be a malabsorption of these different nutrients. We looked at things to do with the counseling, which came out very key in yesterday's engagement, where we were prioritizing the needs and also being able to clearly explain to those clients what the nutrition advantages will be, and also taking those manageable steps in trying to manage the HIV from progressing, also getting to things with special considerations, things to do with the diarrhea in HIV, and also things to do with the hypolipidostrophy and the hyperlipidemia causing obesity and hypertension. Really, most of those things we looked at yesterday, so you could interest yourselves and go and read about them. So today we are going to be looking at anemia. Okay, and we're going to be looking at the nutritional management of anemia and metabolic stress. So by the end of today, we want you to be able to explain the causes and symptoms and also the consequences of anemia and metabolic stress. And also we expect you to be able to identify the dietary factors that influence the absorption and metabolism, and also the utilization of iron or folate, and also the vitamin B12 and the main nutrients involved in anemia prevention and treatment. And really we will be seeing the channels through which we absorb iron into the body and etc. And also, we expect you to be able to evaluate the nutritional status and the needs of individuals and groups at risk of suffering from anemia and metabolic stress using the appropriate assessment tools and methods, I should say. And also, we expect you to be able to design, implement, and monitor evidence-based nutrition interventions to prevent and treat anemia and metabolic stress, I should say. So when we talk of erythropoiesis, we have uh, things to note here. One, we have the hemopoiesis, and we are looking at this as the production of blood cells and platelets. Okay? This occurs primarily in the bone marrow. I think this little biology, and the major organs involved in this is the liver, the spleen, and also the bone marrow, with the bone marrow being the primary site for the embryonic development of these blood cells. You've heard of the bone marrow transplant, and those are cases where we are trying as much as possible to bring in new cell formation, to start up new cell formation, etc. So you realize that the bone marrow is really key in producing these cells that are required for normal functioning of the body and also the other systems. So for erythropoiesis here, we are looking at only majorly the red blood cells in particular, or the RBCs, as I should say. And we are saying we're dealing with the precursor cells in the bone marrow, so now they become specialized to become the red blood cells. The reticulocytes, larger than the mature red blood cells, are indicating of effective red blood cell production and circulate. Sorry, let's reduce a bit and circulate in peripheral blood before maturing into the red blood cells, I should say. So really we are looking at the origin or the genesis of red blood cell production, as we'll be getting further into details of iron absorption, etc. So maturation in these red blood cells, we are saying that these reticulocytes in peripheral blood undergo membrane rearrangement and use remaining organelles, becoming non-nucleated. When we talk of non-nucleated, meaning then they do not have a nucleus in them. And also these biconcave discs, which is primary characteristic of these red blood cells. So the cell surface markers of the red blood cell precursors, the CD34, the CD71, the EPOR, the EPA, all these play roles in the red blood cell development and function. While if you interest yourselves, we'll go and read a little bit further about them. So now let's look at the major thing here. And what we are looking at here is really hemoglobin. And most of us have understood that whenever we are talking about anemia, even when we are trying to assess for anemia, we try and use hemoglobin as the indicator, I should say. Okay. Yeah. So for the hemoglobin production in sheds, at a precursor stage of erythropoiesis. And you remember when we talked of erythropoiesis, we were talking about a production or manufacture of this production or manufacture of the red blood cells. Okay, yeah. For the factors such as the DTA1, GTA1 and GTA2, all these are responsible for regulating the process of the production of this hemoglobin. So erythropoietin and anemia, we are looking at erythropoietin primarily produced by the kidneys, stimulating the production of these red blood cells. Okay, and also in response to the low oxygen levels. Most of the things in the body, almost of the mechanisms in the body, work using that, I call it the feedback. Yeah, the feedback mechanism, I should say. If something is more in the body, then you will see that there will be a signal that will be transmitted so that less production of that particular factor is done. Or if there are now very low levels of that particular nutrient in the body, you will see that there will be a factor that will stimulate more production of that particular enzyme or that particular factor that is a precursor for the development of the production of that particular nutrient. So recombinant erythropoietin therapy is used in anemia associated to treat anemia associated with conditions like the end-stage renal disease. You remember when we were talking of the end-stage renal disease, when we were looking at diseases to do with the kidney and the nephrons and etc. And also the chemotherapy when we are treating the cancer. Okay, so for anemia, we are saying this is characterized by reduction in the hemoglobin concentration in blood below the normal range for a particular age and sex. These ranges are standard and we will be seeing them. For laboratory screening tests, these include the hematocrit, the mean cell volume, the mean cell hemoglobin concentration, the red cell distribution index. All these are aid really in the diagnosing of anemia. And also we are looking at the blood film analysis. Here the blood film analysis is essential in all cases of anemia, helping to identify the abnormalities, okay, such as the poikilocytosis, which is really the abnormal shapes of these red blood cells, and also that can provide diagnostic insights. Really, we will be looking at the different case to do with the sickle cell anemia. And at the end of the day, that will be how we will be indicating the nutritional interventions for patients suffering with the sickle cell anemia. But truly, here we are looking at it in a general term. So for the iron deficiency, we are saying this is one of the most causes of anemia. And really, iron is the essential mineral that plays a key role in the oxygen transport, the synthesis, and the production in the body. You realize that hemoglobin, when bound to by iron, iron binds to all the four groups of the heme. Okay, then it is being transported into the cells of the body, and whenever it reaches those cells that really have low concentration of the iron, then it is reduced. So they leave the oxygen there. Okay, yeah. So they go and pick up, they bind to other oxygen as they are moving around in the body. We will see that later. Causes include limited absorption and also excess iron loss due to hemorrhage, but also we could talk of nutrient interactions or the drug nutrient interactions, whereby now there is restoration and we are failing, oxygen is failing iron actually is failing to bound to its receptors so that it cannot be easily absorbed. For the iron absorption and distribution, really, it is really a little complex, as you will see a lot of things. We'll just be skipping them to talk about a few of those that we really need to know. Really, iron absorption occurs primarily in the duodenum and with him being absorbed through the membrane receptors. And also, the iron distribution involves the action of the transferrin, the ferritin for storage, and the hepcidin for regulation. So, really, this is the iron absorption and distribution picture. We will be referring to it as we go back and forth. But key point to note, we have what we call the non-heme iron. Okay, this non-heme iron is the iron that we get from the plant sources of iron, the dark green leafy vegetables. And for the heme iron, which binds to the myoglobin and the hemoglobin, really, this is the iron that we get from the animal sources. Okay, yeah. And for non-heme iron, it begins with ferritin, or what we call the uh, iron 3, and then it is reduced to iron 2, or what we call the ferrous iron. It could be done here using this reductase enzyme that is on the border boundary that will help it to be transformed into this ferrous iron, and it is then transported using this DMT, divalent metallic transportase or transport one that transfers this iron into the body, and then it will be stored as ferritin, then ferroportin, and then when ferroportin is in the body, that will show that there is a lot. When it is in the cell, sorry, that will show that there is a lot of iron. Then that will some of that iron that is not bound to, which we call the apotransferrin, will be expelled out of the body, I should say. And let's appreciate it further on this next slide. We are looking at iron is released from bound food components, and we are looking at activity of the HCl or the hydrochloric acid in the stomach, which may reduce this insoluble, or what we call the iron that is not to be absorbed. The iron 3 is the iron that the body does not absorb, but the iron 2 is what the body really requires, and it absorbs. So the free heme is absorbed intact by the heme canal, which is the HCP1. You can see here, HCP1. And we are saying that after it is being absorbed, this is located really at the proximal small intestine. Within the enterocyte, the heme is catabolized or broken down by heme oxygenase to photo porphyrin and iron 2. If you look here, you'll see the heme oxygenase into photoporphyrin and iron 2, that you see it being broken down there. For the non-heme iron, really in the small intestine, it might react with more inhibitors, which promote the fecal excretion of iron, and also the reductases, mainly the duodenal cytochrome B, catalyze the reduction of the iron to or the ferritin into the ferrous iron. So we've seen the issue of the divalent metal transporter 1 being able to transport this ferrous iron across the border membrane of that cytosol of this enterocyte through endocytosis. Then also we are looking at iron being able to bind to the PRC binding protein, or the PCB, for the transport into the cytosol. Sorry, and iron may also be used within the cell and also stored as ferritin, as we saw. So the ferritin transportation transports the iron to the basolateral membrane, and then the iron transport is coupled with oxidation by oxidation to iron 3 by asphyrestin, and also this really the cycle continues, whereby then the iron 3 attaches to transferrin for transport into the blood, like you should see. But really, key points to talk away here that there are two forms of the iron: the non-heme iron and then the heme iron. The non-heme iron from the plant sources sources, and then the iron from the animal sources. And we've seen the reaction from the stomach acids, the HCl, and also all these have the carrier proteins that are key in transferring or transporting this iron throughout the cell. And also we've seen the role of the reductase enzyme that is key in helping in the absorption of the non-heme iron, really. All right, so let's proceed. Regulation of iron, we are looking at the regulation of iron in the body involves a complex balance between iron intake, the absorption, the storage, and the utilization. Like we will say that the intake really, we are talking about the iron that is being consumed from its dietary sources. The dietary sources of iron, like we know, the eggs, the meat, the beans, and also those fortified cereals, because you remember we talked of fortification now being another intervention that will help the public really meet nutrient requirements at the end of the day if they are not existing naturally in that particular food. We are trying to use our food as a vehicle to deliver those other nutrients that are lacking, or the ones that have been removed through maybe processing and all those other things. So the recommended dietary daily iron intake varies depending on age, sex, and physiological status. We really know that the different age categories require different amounts of iron daily intake. And for the regulation of iron, we are looking at its absorption, really, which we've said occurs in the duodenum and in the jejunum of the small intestine, and it is influenced by several factors such as the heme or the non-heme iron, the presence of enhancers, the vitamin C, and the inhibitors such as the phytates, etc. for the iron absorption, and also the iron status of the individual. When we look at the iron storage, and we are saying this one is mainly in form of ferritin, okay, and the hemosiderin in the liver, spleen, and the bone marrow. That is not the one that we use, okay, and the muscles. For the amount of iron stored depends on the balance between intake and utilization. The excess oxidating damage to cells and tissues. Yes, Cho, please can you mute? Cho? Cho, I'm getting some feedback. I hope you can mute. Okay. Going forward, we're looking at the storage form of iron, and we're looking at it being stored as a ferritin, hemosiderin in the liver, spleen, and also in the bone marrow and muscles. And the amount really we are saying depends on the balance between what we are taking in and what we are utilizing. And we are also saying that excess iron can be toxic, as it can cause oxidative damage to cells, because oxygen will be binding to this, causing oxide to be melted into the body. Okay. For the regulation of iron, we are looking at utilization. We were looking at intake earlier and absorption, but now we are also looking at utilization. So we are saying iron utilization refers to the incorporation of iron into the functional molecules, okay, such as the hemoglobin, the myoglobin, the cytochrome, and also the enzymes. And the demand for iron increases during periods of rapid growth, the pregnancy, the lactation, menstruation, and infection. This we saw when we were looking at the daily requirements, and also looking at the different categories requiring different daily intakes. This is why it is also key whenever you're talking about complementary feeding, that children need to be given foods that are rich in iron, so that now a lot of other factors due to in development can occur, because iron is really key, and it has been found that it is really key to be given during the development stages. And also you realize that now the energy store, other iron stores in the body of an infant have now been depleted, okay, at 6 months. So that the child needs to be given more iron, more foods rich in iron. The regulation of iron is controlled by the hormone hepcidin produced by the liver in response to changes and also the status and inflammation. So this hepcidin inhibits iron absorption by binding and degrading ferroportin and a protein that transports iron out of the enterocytes and the macrophages. Okay, so this hepcidin also reduces iron release from storage sites and its availability for electrolysis. So whenever this hepcidin is initiated or it is produced, then we know this is negative to the iron production and iron absorption, I should say. For the hematinics, the hematinics of iron deficiency, we are looking at hematinics or nutrients required in RBC, red blood cell production, assessed through serum levels of iron. Okay, serum ferritin, and also we are looking at the iron binding capacity, or what we call the total iron binding capacity, the IBC, as we will see. So in iron deficiency, the serum iron decreases while the total iron binding capacity rises. So as for the iron to be able to bind to more parts or to more areas of the cells. The treatment of iron deficiency, here we are looking at treatment involves oral and parenteral supplementation. When we talk of parenteral, I hope you remember that when we talk of parenteral, we are putting nutrients directly into the blood vessels, I should say in the veins to be more specific, with the ferrous sulfate being the common oral option. Then for the parenteral, iron is reserved for cases requiring high iron levels. So for the vitamin B12 and the folic acid deficiency, remember when we talked of iron, we are not talking of only iron deficiency anemia, sorry. When we talk of anemia, we are talking of only iron deficiency anemia, but we are also talking about metabolic anemia and all those other forms of anemia. Also there is apoplastic anemia. I beg to be corrected if I'm not giving the correct pronunciation of that. So for the deficiency of vitamin B12 and vitamin folic acid, this can also cause anemia, with pernicious anemia too being a common cause of vitamin B12 deficiency. And here the diagnosis really involves assessing the levels of B12 and folate in blood. So for the pernicious anemia, this is caused by an autoimmune attack of the gastric ulcer, leading to the decreased intrinsic factor production. The intrinsic factor production is that one that is required for binding of these substrates. And also when we talk of an autoimmune attack, remember when we talk of autoimmunity, this is where the body is failing to recognize itself, and it is secreting antibodies to deplete itself or to fight against itself, leading to damages in the long run. And also the bit of absorption involves binding to the intrinsic factor in the ileum and also transportation via the transcodalamine, etc. For the folate absorption and function, so you know that we tend to prescribe folic acid for the pregnant mothers and also those who are trying to prepare for a conception. It is, it is only in Africa here that people get pregnant by mistake. But in developing countries, and also for people like you who now have the knowledge of nutrition, even for the men, you need to prepare for when you're going to get your wife pregnant, so that they have that I call it the pre-pregnancy diet. Okay, so that when this person becomes pregnant, you're just topping up on those nutrients, or you're just topping up on those nutrient stores, I should say. So for the folate absorption, this occurs in the small intestine, with the dietary folate being converted to active forms for the cellular use. So both this folate and the B12 play crucial roles in DNA synthesis and also the methylation process. Diagnosis involves assays for the serum B12 and also the folate levels and also additional tests such as the homocysteine levels and the antibody studies for confirmation of these nutrients or levels of nutrients of B12 and folate, I should say. So for the cell red cell folate, this is more accurate guide for the tissue folate status and in absence of the B12 deficiency, really. So introduction to the metabolic response to stress. What is that a response that the body gives to stress? You know, the body works in a response feedback mechanism that yeah, we work in negatives and positives. If something is being contraindicated, then what the other thing will be indicated and etc. So for the metabolic changes occur in stress response, which can range from uncomplicated to severe stress associated with trauma, or what we call trauma, the disease, and also surgery. So in inflammation, the body responds to stress with hormonal and metabolic changes, which can suppress the immune system and also involve the central nervous system and the different hormones. And you know, a lot of information has been given out regarding on the function of the different hormones and their triggers, I should say. So the vicious cycle and the immune system, we are looking at the impaired immunity increasing the risk of disease, compromising the nutrition status, which also further impairs the immunity. Okay, so if your immunity is impaired, it will increase the risk of disease. The risk of disease at the end of the day will lead to you becoming malnourished, and you becoming malnourished will lead to those micronutrient deficiencies. And those micronutrient deficiencies will further impair the immunity of the individual. So that is why you see that nutrition is a key player in the immune system. That if the person has a normal nutritional status, really the opportunistic infections and other comorbidities will find it hard to compromise this individual. So nutrition plays a crucial role in supporting the various immune system components like we mentioned. And we are saying that the malnutrition affects the gut microbiome communities, the skin integrity, leading to poor wound healing, poor nutrient absorption, and also it will impair the antibody production. And once antibody production is impaired, really infections will compromise the health of an individual. So the stress response here, we are looking at the body's response to stress, which involves hormonal changes affecting various systems, including the aldosterone, the antidiuretic hormone, like we saw in the kidney disease, the adrenocorticotropic hormone, and also the catecholamines, the etc. These hormones really, it's something we need to do in broad so that we understand the different hormones and when they're secreted and what do they really do. Effects of starvation, we are looking at this leading to glycogen depletion. Remember that the storage form of glucose in the blood or in the body really is glycogen, and also lipid mobilization, then the gluconeogenesis. Gluconeogenesis is still to do with breaking down of glycogen into glucose, and also muscle protein catabolism. Muscle protein catabolism, we are looking at the breaking down of this protein that is formed in the muscles, leading to wasting, etc., and also ketone body production. We talked of ketone bodies being the byproduct of metabolism of protein. So these ketone bodies will soon lead to ketoacidosis and then also further impair the individual. So for the severe stress, we are looking at food and nutrition therapy really, and we are saying here this will lead to hypermetabolism, okay, characterized by EBP and the flow phases, okay. So for the protein requirements increases during the stress, along with increased needs for the vitamins, the minerals, and also other fluids. Really, during stress, we are looking at an increase in these protein requirements, surely. Okay, yeah, you know, because we need to account for all those losses, etc. And for the effect of stress on protein metabolism, we are looking at protein is mobilized for energy, which shouldn't happen. Okay, resulting to decreased amino acid uptake by muscle tissue and also increased urinary nitrogen excretion, like we saw during the kidney disease. Effects of stress on carbohydrate metabolism, here hepatic glucose production and insulin levels increase, leading to elevated glucose use. Okay, and the effect of stress on fat metabolism, we are looking at fat mobilization from adipose stores. Here is where we talk of the abdominal fat deposits, but rapid depletion without feeding can lead to malnutrition and also increase the infections or increase the risk of infection. And also for the stress on fluid and hydration, we are looking at increased fluid losses possible due to fever, diuresis, diarrhea, wounds, and also diuretic therapy that happens during stress. So, what is the effect of stress really on the micronutrient metabolism? Really, this is key where people need to pay attention. That they will ask you what will be the impact of stress on the particular nutrient, beginning with the protein, the fats, the carbohydrates, etc. We are looking at for the micronutrient metabolism. Here, the increased stress leads to higher requirement for most of these micronutrients, the vitamins, the minerals, etc., especially the vitamin C, beta carotene, and zinc. So, recommended supplementation of 500 to 1,000 micrograms of vitamin C or milligrams of vitamin C daily, and also 220 milligrams of zinc sulfate daily when the individual is experiencing stress. Right. So indirect calorimetry accurately determines the resting metabolic rate. I hope you remember this when we're talking of the basal metabolic rate. And really, it is almost the same as the resting metabolic rate when we are talking about that energy that is required for the person at their resting phase or when they are not when they're not engaging in physical activity. The energy required by your body to do those involuntary activities like the breathing, etc. So overfeeding can be more harmful than underfeeding of these critically ill patients. So really, if we are having patients that are experiencing stress, we should not be indicating a lot of feeds into them, causing shock to the system. Okay, so really overfeeding, we've seen this a lot in our various engagements. So surgery. Upon surgery, malnourished patients must be identified early to prevent complications. Okay, and also there is a term of pre-surgery nutrition. I think either we looked at it or we've not yet looked at it, so that it's not that everyone will just start surgery there and then. You realize that they program your body using the different nutrients. etc. Some people even take supplements before their due dates for surgeries. If someone is to take a surgery next month, they can begin preparing early this month for that surgery, and they will be working in close collaboration with health workers, including nutritionists, to see how they can manage this surgery, post-operation, and pre-surgery management. So undernutrition can lead to decreased protein synthesis, weakness, and also multiple organ dysfunction syndrome, or what people call the multiple organ failure, where the liver is failing you, the kidneys are failing you, and etc. Dietary sequence after bariatric surgery progresses from clear-free into regular meals over the several weeks after surgery. So after surgery, really, we are not looking at giving the individual food there and then, okay? Yeah, but we begin by a small food. Some people have even talked of enteral feeding after surgery, but really after bariatric surgery, which involves things to do with gastric bypass, things to do with gastro ostomies and what, like we had seen during the internal feeding. Surely we begin with the foods as we are progressing to the more solid foods, the purees, etc. Uh, High risk surgical procedures, certain surgeries like the hip replacement, the open heart surgeries, all these carry high risks of malnutrition related complications. Okay, and really we need a multidisciplinary approach uh, 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 for managing patients that are undergoing these high risk surgeries. So you need to be on board as a nutritionist. You need to know what impairments will happen after this surgery is done, or what things are supposed to be less indicated during the surgery or after. Okay, so under trauma, for patients with traumatic brain injury, what we call the TBI, these ones experience a hypermetabolism. And when we talk of metabolism, we are talking of both catabolism and anabolism. Anabolism building, catabolism breaking down. I think that is on a layman's language in our understanding. Let's go with that. And catabolism necessitating careful nutrition requirements. For issues with a systemic inflammation response, which we call the SARS syndrome and multiple organ dysfunction syndrome, this can complicate recovery from the trauma of the patients that we are trying to work on in our health setting. For thermal injuries such as burns, here burns vary in severity from the first degree to the third degree burns, like we all know, each requiring specific care. And here the nutrition support is crucial in burns, focusing on the fluid and electrolyte replacement, because in burns really a lot of fluid is taken out of the cells. Okay, then it is taken out of the tissues and etc. And also the early enteral feeding to decrease hypercatabolic response, and also micronutrients, especially the vitamin A, vitamin C, and all these should be carefully monitored and supplemented if necessary. So, friends, today we were looking at really things to do with iron, and we're looking at the different forms of anemia, looking at folic deficiency, looking at iron deficiency. We've also seen how iron delivers oxygen into the body, etc. And also we've been looking at stress, trauma, and surgical operation. So friends, this brings us to the end of today's engagement. Unless otherwise, I would like to wish you a nice weekend. Let's meet on Monday. We were supposed to meet today evening on Sunday, but really I can't make it. I apologize. So let's really give it a rest for Sunday, so that I also recover my voice fully, so that I can be able to deliver better on Monday as we go into the other progressing weeks. I wish you a nice weekend, friends. James, you want to say something?
Yes.
Yes, please, go ahead.
Good afternoon, sir.
Yes, good afternoon, James. How are you?
Yes. Thank you very much for taking us this beautiful lecture at this particular moment.
Yes.
It is very nice that everyone is enjoying. Now, let me ask also concerning about also how maybe a nutritionist person, or maybe how you can handle maybe the case of the burns when happen, because I've also heard about the electrolytes uh, treatment that we can use in terms of feeding. But what do you do as maybe as a nutrition person in order for you maybe to manage that burn injury?
Okay, thank you very much. I realize whenever we talk of burns, thank you for that question, really. When we talk of burns, we understand that nutrition plays a very key role in this, okay? Yeah, and things to do with the energy requirement because burns can increase the body's energy expenditure, due to those metabolic demands of wound healing, tissue repair, thermoregulation, etc. And really, it is essential to provide foods high in calorie. When we come and talk about protein intake, we are looking at wound healing, tissue regeneration, and also prevention of more muscle breakdown. And also, like I said in our engagement, we're looking at fluid and electro balance because burns can disrupt this in the body, leading to things to do with dehydration and electrolyte imbalance. Okay. Yeah, this could bring some complications. It could result into shock, and also really we understand that adequate hydration is essential to maintain the blood volume and also support other organisms or the other organ functions, etc. So really, that is what we could talk about here. Okay, yeah, and also you talk of the nutrition monitoring, you talk of the vitamins that are essential in supporting the immune function to avoid those opportunistic infections from coming in. You could also talk of the enteral nutrition and etc. But really, things to do, we are looking at the nutrients that are supposed to be indicated and what roles do they play. So that's how you can manage using the knowledge you know about the nutrients and what are those disadvantages or those complications that could arise from the burns injury. I hope I've answered you.
Thank you very much, sir. Because it is good that you should also know as also a nutritionist person or as a student because it is also a college that you want to specialize with because it is good that you should also know the procedures of how you can manage maybe a patient with a burns. And at the same time, lastly, maybe I would like to know is any kind of also of a feeding or that maybe should be allergic to the person experiencing burns.
I didn't get that clearly.
Okay, what I'm asking just I would like to know that maybe do we have any kind of maybe a feeding process or maybe any kind of nutrient that should be allergic for someone who is experiencing a burn?
Is someone getting him clearly?
Okay, I'm trying to know about now because there is some other food that when you take maybe it might be allergic to your body. Is any
Oh, I,
kind of a
I, I,
food?
get, I
Yeah.
get you now.
Yes.
Yeah. So for the burns, really, most people talk of highly spicy foods. People talk of foods that are rich in sugars. People talk of alcohol being limited and etc. And also other people look at things that could irritate the digestive tract and also worsen the gastrointestinal symptoms, etc. But really, most people are talking of the literature I was reading was only talking about spicy foods and foods with high fat. But people have also talked about beverages, people have talked about alcohol should be contraindicated when people are having these burns. This could increase the risk of infections and dehydration and also liver dysfunction, etc. Yet we are having this burn on us that requires a high energy intake and high energy requirement. Really, those are the things that have come across, but you can go and do a lot of reading about it. And also, there is information on different people are facing this differently. Okay, yeah. So some people face challenges with the burns themselves, but then other people have their own allergic reactions. Okay, so if we understand that a food is causing an allergy to an individual, then we can also contraindicate that as a form of treating these burns. I should say. Does that answer you?
Thank you very much, sir. This is what I also like to know because as time coming, because some also like you mentioned.